Thank you. Good morning, everyone. Glad to have you. Um, our webinar objectives today are first to recognize a mental health or mental illness and or diagnosis. Also to determine the best approach to managing a mental health VR case, developing strategies for service provisions to participants whose diagnosis is a mental health disability, and also to assess the impact of mental health issues in our communities. This is the second in a series of webinars focusing on tribal vocational rehabilitation services and mental health care. And our presenters today are Teresa Brewington and Sean Baird, both with the Native Behavioral Health Technology and Transfer Center at the University of Iowa. Here's some information about the TTCs. The content of this webinar, it was created by our presenters. The funding is provided through SAMHSA, and we're just glad to have them with us today. A little more about our speakers today. Our presenters are Teresa Brewington. Teresa is the program manager for the National American Indian and Alaska Native Mental Health Technology and Transfer Center, K-12 school supplement. She is an enrolled member of the Kahari tribe and a descendant of the Lumbee tribe. She holds a master's in educational leadership, a master's in business administration, and 36 credit hours towards a master's in counseling. She's held positions as a director at several mental health agencies and has worked as a school guidance counselor, serving mostly Hispanic Latino students. She's also served as a foster care agency supervisor. She's worked directly with the Salt River Pima Indian community in Arizona and has also worked placing Native American children in foster homes. Her last position was as an elementary school principal for Native children at the Meskwaki settlement located in Iowa, where she currently resides.
Hi, Jamie. This
Sean
is
Baird
John.
is also our person. Yes.
Sorry about that. We had one request for increase in volume on your part. I don't know if you want to switch over to the headset or not.
Yeah, let me put my headset on real quick.
Okay, thank you.
Sure. And can everyone see the screen with the information, with the bios for each of our presenters?
And while we're waiting, we're trying something new today. If you'd like to go download this slide deck as a PDF, please follow the link above, and you can follow along that way if you'd like, or have this as a reference for later. Thank you.
How's that? Is that better?
Sounds good to me.
Okay, great. Okay. And our presenter also today is Sean Baird. He's earned his bachelor's from Buena Vista University in 2000.
Sorry about that.
I'm not sure who that is.
I muted the microphone.
Okay, thanks, John. Everyone check your microphones because we were picking up someone's background. Sean earned his degrees from the Buena Vista University. He is majoring in psychology and human services. He also double majored in mental health counseling and vocational rehabilitation at Drake University's graduate program. He's a member of the Meskwaki tribe located in Tama, Iowa, and he's worked with Native Americans with substance use disorders for many years. He's also an Army veteran of 9 years, honorably discharged from the 82nd Airborne. He's also worked as an administrator, counselor, as well as a counselor in adolescent behavioral programs, substance abuse treatment, and in-home family therapy. He also has experience building holistic Native American-based curriculum, as well as implementing it with substance abuse clientele. And he's been training coordinators for the National American Indian Alaska Native Training Technology Transfer Center from 2013 to the present, where he currently serves as co-director. So I just want to thank both Sean and Teresa for being with us today, for putting this presentation together, and I will go ahead and turn it over to them.
Can you guys hear me?
Yes.
Okay. Hi, my name is Teresa Brewington, and I am very glad to be here today. I am going to start with the diagnosis portion of this PowerPoint presentation. I do need to recognize and say that this information is coming directly from the DSM-5 because it's very important for those that are treating and working with those with the mental illness, refer to the DSM-5. The DSM-5 was developed by the American Psychological Association and is the official diagnostic and statistical manual for mental disorders. It's used by those working with clients with mental illnesses. The DSM-5 was developed in 2013, and it's the newest version from the DSM-4. According to the DSM-5, there are now 157 mental health diagnoses. It is the handbook that's used by healthcare professionals in the US and other parts of the world. It also contains descriptions, symptoms, and other criteria for diagnosing. The picture shown above shows you an array of diagnoses that is found in the DSM-5. It is very important to note that 1 in 5 US adults experience a mental illness. 1 in 6 US youth age 6 to 17 years of age experience a mental health illness. And 1 in 25 US adults live with SMI, a serious mental illness. Brain chemistry plays a major role in mental illnesses because the imbalances in the neurotransmitters, which is why we often medicate those with the mental illness. The chemical messengers in the brain, those are the chemical messengers in the brain. Another cause of a mental illness could be in addition or alone are the environmental exposures, life experiences, substance abuse during pregnancy, and are all major contributors to mental illnesses. For example, enduring traumatic events might cause a condition like PTSD, while repeated changes in primary caregivers in childhood may influence the development of an attachment disorder. Mental health disorders can be diagnosed from a physician, examination, psychologist examination, and evaluation. Most psychiatrists or psychologists use the APA's Diagnostic and Statistical Manual of Mental Health Disorders, the DSM, to diagnose mental health illnesses. Mental health illnesses are not considered curable, but are considered treatable with the right medications, therapy, and treatment plans. You could have bipolar and other related disorders induced by certain, yes, I wanted to go ahead and say that. You could have, actually, I'm not going to say that. Go ahead and go to the next slide. Sorry about that. Can you hear me?
We can.
Okay. So to talk a little bit about the types of mental health disorders. These are just some of the types. These are the most popular types. There are also subtypes in each one of these types. Anxiety disorder, for example, is a condition that shares features of excessive fear, anxiety, and related behavior disruptions. Some common examples are separation anxiety, phobia, social anxiety disorder, panic disorder, and generalized anxiety disorders. There are even anxiety disorders due to other medical conditions, which means they're caused by medical conditions. Symptoms can include nervousness, tenseness, increased heart rate, feelings of exhaustion or weakness, trouble sleeping. GI problems are often found in these individuals. They often worry about things. They have trouble concentrating, and many are constantly focused on fears. Depression is the presence of sadness, hopelessness, emptiness, or irritable mood that is impacts the individual's functioning. These disorders can cause feelings of sadness and loss of interest in everyday living and normal activities, hobbies, or sports. There are several subtypes again, such as major depressive disorder due to another medical condition, substance abuse or medication-induced depressive disorder, anxiety, agitation, restlessness, and feelings of worthlessness or guilt, fixating on past failures or self-blame is a major contributor to depression. Those with depression also battle with thoughts of death, suicidal thoughts, and suicidal attempts. Bipolar disorders, formerly known as manic depression, a mental health condition that causes extreme mood swings. If you've ever worked with somebody with bipolar disorder, you normally see them when they're going through their episodes as extremely high, which is mania, which means they're extremely high on life, funny, laughing, just silly, or they're very, very low. There's no middle ground. They're very high or very low, extremely happy, extremely suicidal or depressed. When they are in the manic state, they do not show any balance. Instead, they are either, like I said, high or low. Psychiatric disorders, psychotic disorders. One of the main ones that we hear for psychotic disorders is schizophrenia. It has features such as delusions, hallucinations, like seeing and hearing sensories, things that are not really there. They have disorganized speech. They lack expression. They're very disorganized. There is a schizophrenia spectrum, and there are also other psychotic disorders into this category. Psychotic disorders cause detachment from reality, which means they may hear or see things, and to them, this is real. I'm going to talk about co-occurring disorders separately, so we could go ahead and go to the next one if that's okay. So next slide, please. Seriously mental illness, and this is the folks that you guys are mostly working with. Seriously mental illness, SMI, is defined as a mental, behavior, or emotional disorder resulting in a serious functional impairment which substantially interferes with or limits one or more major life activities. And that is how they get diagnosed. It has to interfere with one or more major life activities, and it's ongoing. Two of the most common SMI diagnoses are bipolar and schizophrenia, and also major depression. But there are other disorders that are also causes of a serious mental illness. SMI, as I said, is long-term, is ongoing, which is why we work with people that are SMI that normally are on either SSI or SSDI. Substance abuse does not qualify someone with SMI. Most overly represented conditions found in SMI patients, like I said before, is schizophrenia, major depression disorder, and bipolar. But again, there are several other SMI qualifications such as anxiety disorder, even PTSD, borderline personality disorders, and even eating disorders that can qualify you as an SMI client. SED, serious emotional disturbance, is diagnosed mental behavior or emotional disorder in children. So SMI patients are only 18 and older. SED are those up till 17 or prior to their 18th birthday. In 2019, it was estimated that there was 13 million adults in the US age 18 older, and older that had an SMI diagnosis. That means that 1 in every 25 adults are SMI diagnosed. The presence of SMI is higher amongst females, 6.5%, than their males at 3.9%. Young adults, 18 to 25 years of age, have the highest rate of SMI. Prevalence of SMI was highest amongst adults reporting 2 or more races at 9.3%, followed by American Indian and Alaskan Natives at 6.7%. Unfortunately, life expectancy for those with SMI is around 52 years of age compared to the average life expectancy of 77 years. That's a 25-year difference. Suicide and other causes such as lack of effective mental health treatment and care, the use of substance abuse and overdose. SMI patients are 3 to 5 times more likely to abuse drugs and alcohol. They experience a lack of poor nutritional habits, poor and risky life habits, homelessness, incarcerations, poverty, trauma, compliance with treatment. Effective support and treatment can greatly improve their quality of life and life expectancy. Treatment programs for SMI patients should include an array of approaches to include psychologists, peer specialists, VR specialists, counselors, positive self-help, correct medications, caseworkers, treatment plans, and should help them function to their full potential and quality of life. Next slide. So a little bit about, go ahead and next slide, Jamie. Okay, dual diagnosis. Dual diagnosis, according to NAMI, which is the National Alliance for Mental Illness, which is a very good resource, along with DSM-5. NAMI suggests that a dual diagnosis, also called co-occurring diagnosis, is a term used for a person who experiences mental illnesses and substance abuse disorder at the same time. The dual diagnosis co-occurring, it's co-occurring because it's present there at the same time. So a lot of people refer to it as co-occurring versus dual diagnosis, but they're both one and the same. For effective treatment, it is imperative to treat these together. So if someone has a mental illness and a substance abuse, and is also using some substance abuse or alcohol and drugs, it is imperative that they treat these together. However, oftentimes we do not. It is also very important to note that when people are presenting with a mental illness and also are on drugs or alcohol, it's almost impossible to give them a correct diagnosis. Sometimes they will not even give them a diagnosis until they are free from the use of alcohol and drugs, because the substance abuse or alcohol will mimic what the mental illness could be, and they will oftentimes get misdiagnosed. It can be very hard to treat. However, with the correct support systems, dual diagnoses are absolutely, like all the other mental illnesses, very, very treatable. Unfortunately, in a lot of areas, depending on where you live, providers are not equipped to help people with dual diagnosis. So it is something that is oftentimes very discouraging for the patient. People with dual diagnosis will often spiral into self-destruction. Physical signs include signs of withdrawal because of the use of alcohol and other drugs, sleep pattern changes, weight loss or gain, poor personal hygiene, red or dilated eyes. Behavior signs include lack of motivation, feelings of paranormal or anxiety, isolation or withdrawal, and a lot of them also have legal and financial issues. And this is just to name a few. Next slide. Okay. And Sean's going to speak on this, but I did want to make sure if Sean or Jamie wanted to add to anything that I said before we move on.
Glad you explained the dual diagnosis, because I think a lot of times we feel like a dual diagnosis means, oh, well, they have more than one disability or more than one mental illness. And the fact that it coincides with a substance abuse or alcohol abuse disorder. Thank you for explaining that.
You're welcome. And it's unfortunate because when you have a mental illness, what do we do? You know, and that's why a lot of people with mental illnesses do self-medicate, and they self-medicate with alcohol and other drugs. And I can also say that when you have a mental illness and you are seeking treatment and are seeking medications, there is no one right fix for everyone, especially when you're working with the medications. Just because they give you a medication, it does not mean it's going to work. It's kind of a trial and error. A lot of times when people first get into this realm, they have to go through several medications before they find the one that works for them.
Thank you. Does anyone have any questions? We have any comments about actually diagnosing or recognizing a mental health diagnosis?
Well, one thing I'd like to make sure people remember is that when people come in for a dual diagnosis, is remember to assess these separately. And normally in the beginning, maybe till about 2 or 3 weeks sometimes, the first part is pretty much making sure they're okay, getting them back to balance and stuff like that. And then after that is usually when you can find out whether something is a mental health issue or not. Because normally it's like the effects of substances, depending upon what they are, may affect them and give you the wrong conclusion about mental health, but also with withdrawal symptoms. Like for instance, those that are considered like downers, when people are withdrawing, of course their body speeds up and it's more like a manic episode, kind of like it can be, but anyway. And those that are uppers, when they go down, when they're going through withdrawal, normally everything drops. So that's usually when you see depression. So a lot of times during anxiety or depression in the beginning can be very normal. So remember, it takes some time to be able to assess mental health, possibly a little later, but of course watch that to make sure that they're okay with those things. Also within different diagnoses, when you're looking at some of those that are including hallucinations or delusions, to make sure that those aren't something more culturally based. A lot of times what has happened in the past is there's been Native Americans who may be diagnosed with mental health issues only based upon their belief systems. So if our culture says that we believe in spirits and ghosts and things like that, at times people from another culture may take that as delusional. And as we know, many of the Native Americans also have, an ability to be able to see things or hear things, sense things. Not everybody does anyway. So that too might be taken out of context when it's still a cultural thing. I do know that was brought up way early on, I think back in the 1980s, 1990s, when they had looked up for the split feather syndrome. And many of the children were diagnosed with mental health disorders. But they later found that it was cultural and that they shouldn't have had those mental health issues. Thank you.
This is Philip. When a provider is prescribed medication, don't they do it on a trial period to see if it works, and then maybe switch to another type of meds?
Yes. Is that Philip speaking? Yes, Philip, they absolutely do it on a trial basis. Oftentimes, unfortunately, what I have seen is they will send a patient home with medications. The patient will take the medications are not working, the patient doesn't return. Unless maybe till the next episode, and then they go back. And we see that a lot, especially with our youth. I also wanted to add too that a lot of diagnoses do not come about until you are an adult or a young adult. We used to hear that, no, when you get mental illness, you will see the experience of a mental illness early on, but that's not true. I could also tell you that a lot of these mental illnesses can be caused by, for example, heroin. We have had and seen clients that have, from a result, and they may have had anxiety or something as a a child or a young adult, but then they go and use drugs, which is now manifests itself into other things such as schizophrenia and bipolar. But thank you for the question.
Yeah, I have another question. Well, this is so in Alaska where we have real dark winters. And someone who is bipolar, they mainly have episodes in the spring when we start to get a lot of daylight. And it's been theorized that they have it during the dark days, but they don't know what to do with it. That's why it all comes out when we get more daylight.
And that makes a lot of sense. And I have heard it, I don't know, and I don't know that, and this is my personal experience and what I have been taught and heard. I do not know that there's actual research that supports it, but that a lot of our mental illnesses are very prevalent in the winter months because it's winter and it's cold. We may not be as active because of that. So for you saying that it's manifested itself in the summer months makes perfect sense.
Yeah, it's kind of interesting culturally is that, the way I was taught with bipolar is that it usually stems, culturally, it usually stems from some trauma in the past, somebody's life. And it's kind of neat how new studies are starting to find out how trauma affects people. And that it's actually kind of affects the DNA and that people can pass that on. So it's very interesting how some of these stress chemicals within the body can affect our brains. So I do know that like in Alaska, there's certain times they do give them vitamin D and things like that if they're having a lot of issues.
Jamie?
Yes, sir.
This question is for Teresa and Sean. Good morning. This is Lee with AIVRTTAC. I recently had a conversation with a native psychologist who works on one of the reservations here in Arizona, and she was sharing with me that that some family members are bringing in individuals who are abusing meth and are also displaying behavior that resemble someone with schizophrenia or bipolar. And the clinic is not set up to work with these individuals if the family is making a request that the individual be placed in a treatment center. So unfortunately, when they recognize that that they are under the influence of meth and not necessarily diagnosed to have schizophrenia or bipolar, they really can't do anything. And the sad part is, and it's easy to understand that the family members have had just about enough with the family members' behavior. So they dump these family members off at the clinic, expecting the clinic to do something with them. When the clinic can't help them, they really can't do anything. So they assume they find their way home. And it's a reoccurring problem. And I don't know if similar stories has been shared with you, the two of you.
Sean, you want to answer that? Would you like me to?
Well, I do know that with methamphetamine, they do have a diagnosis of substance-induced schizophrenia. Normally, when somebody's on methamphetamine for longer periods of time, they do begin to hallucinate. Delusions begin. What happens is normally if that person comes off of the methamphetamine for approximately 3 days, then the delusions begin to go away. Hallucinations may stop, but some may keep going on, and that's where the issue might arise, because after that, then it may become substance-induced schizophrenia, but normally schizophrenia cannot be as set as the diagnosis right away. They have to go through different time periods to be able to meet those. But you are correct. Methamphetamine, it can mimic the schizophrenia.
And other mental health illnesses, like bipolar. And it's so unfortunate. Dual diagnosis is so hard to treat because of that very reason. One, our psychologists, our doctors, they are not equipped to handle dual diagnosis patients. A lot of them still have the belief that you have to treat the substance abuse first. A lot of them, like I was saying before, will send somebody away because they're saying they can't diagnose them with a mental illness because they're on substance use. However, there is treatment, and there are treatment facilities out there that do have programs to treat specifically those with a dual diagnosis. And new research shows that it is best to treat the mental illness and the substance abuse together. However, I can tell you, even on a personal experience, I know many people who have both the substance abuse use or abuse and a mental illness, but they're being sent to treatment facilities. So they're being treating for the substance abuse, but not treating for the mental illness.
How do you look at a situation like this if you sense that the individual may be a harm to themselves or others? What would be the legal perspective in a situation like this?
Sean, you want to answer? Would you like me to?
Good.
Are you asking what the protocol is if we have somebody that is going to do self to harm or somebody else?
Yes.
I am a mandated self-reporter. If you guys have not been through that training, I strongly suggest that you seek out that training. Anytime, for example, that I see someone or someone comes to me and says that I am feeling down, worthless, hopelessness, I want to die, I'm mandated to report. So, or if someone comes to me and says, I am going to harm this person, I am mandated to report. The first thing that I would do is call the mental health facility here because I'm on a Meskwaki settlement. But that is the time where they have to act. Oftentimes in communities, what they'll do is they'll be screened by a mental health professional and or go to an emergency room where they will be screened. And then go from there. However, I could tell you a lot of times, and I'm going to be honest and say funding has a lot to do with this. Funding in the area and the state that you live in. I'm going to throw this out here too. Iowa is one of the less funded states there are to treat mental illnesses. So unfortunately, what happens to people here is they end up in jail or prison. And that unfortunately is normal for a lot of people with the mental illness. When you are harmful to yourself or others, there is treatment. They will most likely, if you go into that hospital and you tell that hospital nurse that yes, you are going to do this, they are probably going to put you into a treatment facility, but I could tell you that it's a short term. It may be for 4 days, I think is the norm. And then they send you home with a plan. Unless you are still saying, yes, I'm going to kill myself.
Yeah, you have to meet certain standards for that too. What you want to look at is duty to warn if they plan on hurting somebody. And for suicide, it's like you have to meet certain standards, such as, do they have a means to do it? Do they have a plan? And if they meet those requirements, then yes, you can call and have them assessed within the hospital or something like that to be able to hold them, plus at the same time they're safe. A lot of times too, it's like what you can do is also family. Family can get involved, and you can go to the court, fill out paperwork so that they can be picked up and taken. But one thing you have to make sure is if you are doing that, you have to make sure those things are observable. That's the big thing with reporting like that.
Another situation I can share on a personal note is on the Hopi Reservation, the 12 villages are isolated and in remote locations. So oftentimes we rely on law enforcement for assistance. But because of the distances between the villages as well as the health clinic on one end of the reservation, and then a more well-equipped hospital on the other end of the reservation, it becomes a concern for the vulnerable population when they encounter relatives under the influence of alcohol or drugs. So where does law enforcement come in as far as assisting in situations like this?
Oh, Lee. I'm gonna have to pass that one on to Sean. Sean,
Yeah,
you want
a lot of that may come into like for committals, but at the same time, you can always have a self healthcare check, make sure that they're okay. A lot of times, if you do an involuntary committal of a person, then they will pick them up and make sure that they go somewhere to get assessed. A lot of times what you want to make sure though is those people who are on methamphetamine or certain kind of substances is to get through with withdrawal period. Because I do know some substance abuse agencies, what they'll do is before they even allow them into treatment, they'll have them like held for a certain amount of time so that they can withdraw from some of those. That way, when they do reach the treatment facility, they're not on a substance anymore.
And I want to add too, Lee, to that. Yes, law enforcement should be involved and oftentimes are involved. I would suggest making sure that if you are calling law enforcement, that you ask for a welfare check and you make sure that you are telling them that this person is exhibiting symptoms from a mental illness. And as far as commitment orders, absolutely. Commitment orders are extremely important. There's two ways to do it. Someone can self-commit, or you could, and again, every state has its own laws and protocols. But normally it takes at least 2 signatures to do an involuntary commitment when someone is exhibiting behaviors.
Yeah, I was thinking too, that subject in itself could be a whole training. I think because we get into, the different state versus tribal law. How do we, what resources do we have? Tribal versus state, county laws, that type thing. So yeah, we could go on and on about that. And, that's a great idea, Teresa. Perhaps we could put together a separate training on those resources and the protocol for that situation. We probably need to move on.
But great questions.
They really are. Yeah, I like Karen's comment. She said often individuals end up in the ER with emergency mental health issues, and then the sheriff's department's called at the same time, you know, for safety concerns. And then law enforcement will often provide transportation to the nearest facility. But then you have costs that are associated with this. And so, yeah, there probably should be protocol that you follow. And like Karen was saying, you know, when you start getting into costs, then that's probably where you need to really have something in place. So back to our slide.
Okay, so mental health assessments with American Indians, Alaska Natives. One thing to remember is that with mental health assessments, there is no culturally adapted mental health assessments for Native American or Alaska Natives. Normally, when they had begun to utilize the DSM, you kind of look at the history of the DSM. And early on, it began with some people getting together and trying to find out certain criteria that go along with certain diagnoses that they were seeing. Because a lot of times there wasn't a DSM. And from there, it went on to World War I, World War II, where people are adding more mental health issues coming up due to war. With soldiers and stuff like that. Eventually, it kind of did grow into other areas, you know, with youth and things like that, elderly, other kind of illnesses. Even at one time, I think they had, it wasn't called that, but it was a LGBTQ. Back then, they had a mental health, considered a mental health issue. But when this all began, it was not, they didn't take into account other cultures. And when you look at the DSM-5, it's mostly kind of like a US thing, really. They don't have the DSM-5 or DSM system everywhere in the world. So a lot of the cultural knowledge, it's very important when assessing participants for an accurate diagnosis with other cultures. And and a lot of times those cultural factors are not taken into account. So what we have then is some issues with the cultural belief systems being different than how the DSM was kind of formed over time, because it was more formed upon a Euro-American kind of concepts and cultures and their belief system, not the other cultures. Because you'll see with like the indigenous peoples around the world, you know, you'll see a lot of them coming up now, and especially like with Australia, is that the cultural factors need to come into play. Because when we talk about like with natives, talk about like ghost sickness or something like that when somebody's passed away, or when during wartime, and some of those things may be considered delusional with outside cultures. But when you're looking at this, we also need to look at self-identity, the self-identity in which that person says they are. They may look a certain race. You may know them as a native of some sort, but how they identify is very important, because they might not self-identify as a native, depending upon who's around. Sometimes they may say they're native around their peers, or sometimes during different cultural events they make, or with the tribes or different things like that, they might not say that they identify as native or non-native. Sometimes they might not even live with those kind of belief systems or anything like that. So you do need to ask them. Remember that a diagnosis and things like that, which kind of comes to us like you're looking at cultural issues. Now within the DSM-5, it says you must look at the community or the family to look for cultural issues that might play a role within some of these assessments and things like that. But remember that the community must come from that person's community. You can't use a community from all across the world or wherever it might be because they're native. They don't all have the same kind of belief systems, definitely not the same kind of languages. Sometimes there are variances from one culture or one person to the next, or even family to family, or sometimes even a tribe, or definitely tribe to tribe, or village to village. Because the way that we see this is that you have acculturated peoples, you have bicultural people, and you have those that are more traditional. And depending upon how they live and how they believe and what they self-identify as, and that's the way you would normally kind of look at that. So looking at that, we don't stereotype by tribe, beliefs, or practices. I do not stereotype based on one's own professional or cultural bias, because sometimes what happens is that from our professional point of view, looking at another culture, we might believe differently, but we have to be able to go by each individual's needs and their preferences within their culture and their belief system. Of course, there are medicine peoples, spiritual peoples, healers, things like that within the cultures, especially within native cultures. But when you're looking at these kind of things like this, it's very similar to how people look at when they're looking at psychics or something like that. Now, normally people will look at psychics and say, oh, okay, yeah, that makes sense. But it's not always looked at the same way as when they look at the cultural issues. That sometimes that needs to be looked at a little bit more closely. Distress level. You definitely need to look at the distress level of the people. If they say that they're fine, but really you see a lot of distress, the distress level is an indicator that they need help. So if somebody's not distressed at all, and they're talking about their cultural belief systems, then this may be something normal. So remember to assess their distress level. Okay, next slide, please. Okay, so working with people with serious mental illness. Best practices? Okay. Okay, so with best practices, and that's where we're kind of looking at, because what happens, we see as, okay, so we're faced with a lot of different things within the workplace that we utilize now, and a lot of times people want evidence-based practices. Now, if you're looking at evidence-based practices, not all evidence-based practices are evidence-based to other cultures, because normally they have not been studied with those cultures. You might have an evidence-based practice that is utilized for one tribe, but it may not be evidence-based practice to another tribe. Because a lot of times they were studied upon that tribe and their belief systems, their cultures. So when we look at that, a lot of times within the tribes, they take one evidence-based practice that has been utilized with one tribe, and then they readapt that to their own. And over time, that too might become an evidence-based practice. So what we try to utilize is evidence-based practice combined with experience-based practice for best practices. And a lot of times you see that working with the different tribes is that they might already have a program that is working within their tribe. Maybe it could be adapted a little bit or changed. So we have professionals, scientists, whatever it might be, coming in and wanting to give them or provide them with some evidence-based practices that might be helpful to them. Now, normally what we've seen is that a tribe or something like that who already has a practice and adding parts of the evidence-based practice to that is a little bit easier to build and implement than to give them a whole other evidence-based practice and have them add their culture into it. So what we need to do also in working with the people and each individual is to meet them where they are. A lot of times you might see that is if they're ready for an assessment, if they're ready for treatment, if they're ready, and if they are, then you can move on with them. Sometimes you might have to talk to them a little bit in order to help them move on. I know for treatment, to get people moving more into treatment, what I had utilized was some of the information from Maslow's hierarchy of needs. Because what happens is everything physical, in a sense, that they need is provided. So when they go to treatment of some sort, all they have to do is work on themselves. But the big thing is to making sure that they have transportation, making sure that their needs and having their families or children or things like that cared for so that they are able to go and that doesn't hold them back. Being culturally aware. A lot of times people bring up cultural competency now or cultural sensitivity. A lot of people, I think, are coming to the awareness that cultural competency may need to be changed. Because if you're culturally competent with one people, you might not be culturally competent with the same people in other areas or other regions or geographically, because so many of the languages change. Sometimes the cultural changes a bit. The people are a little bit different. Historical trauma, of course, a lot of people are looking more at historical trauma, not just with Native Americans, but with historical trauma, we need to remember to look at that from all this trauma that has happened to the family, their ancestors and things like that, that has happened, could have happened long ago. But at the same time, we're looking at other losses as well, because they might feel they lost their own identity. They may feel or look at the lands that they used to have, the properties or the different things that they used to have, their ancestors, the freedom. A lot of different factors come into play. And even going into areas where there's not a lot of natives, they may be treated differently. So that also is a reminder of this historical trauma as well. So it also has to do with the losses that people face. Can be some of the culture, the language, different things like that. Remember to look at historical trauma. Remember to look at lifetime trauma, because those kind of things come into play. And remembering that when we're looking at trauma and different factors within a person's history, we're also looking at what they call schemas. And schema is something where it's a certain kind of belief system about certain experiences that they expect to be there. So if a certain thing happens, they're expecting this situation to be like other situations that they've had in the past. So sometimes they may become a little more defensive with us or something like that. So remember to look at those things. It's very important to know your client. And one thing good to be able to do this is to build that rapport. And rapport is something to look at that is very highly important with working with the client. That way they can build that client-counsel relationship, make that stronger so the client is willing and able and trusting to be able to speak to us. So that's the importance of building a positive relationship, because they're able to speak to us now. High expectations versus low expectations. They might have high expectations for us, but remembering that we also need to look at them, and during early treatment especially, we don't want to expect too much out of them, because looking at change is very difficult. People turn to substances or to certain kind of things because they've learned that it helps them in those situations, helps them to cope, helps them to deal with things. And now what we're doing is we're saying, oh, you have to leave that behind. And then we want you to do it this way without. So change is going to be difficult no matter how it is. That's why they say that even marriage or having a baby or anything like that is also very stressful, because of all the different things it brings in new to your life. One thing that I've always used to do with working with clients is, I learned it from somewhere, but you write like a paragraph. Don't have to be you don't want it very big, but you write a paragraph on a big sheet of paper. You can have it already ready or whatever. And you have them copy that message on another piece of paper. And you tell them to do that with their non-dominant hand. And let them know, you can tell them, it's like, well, you guys, I don't have much time, just a couple minutes. You guys copy this down with your non-dominant hand, and I'm going to take it to my supervisor. It is part of the way that this person evaluates me with certain things. And then you kind of rush them through that. And then when you're running out of time, you just say, okay, I don't care how you do it, just get it done. And many people, what happens is they'll change from their non-dominant hand to their dominant hand and finish writing it. That is an example of change. And when people are stressed, they go back to what they did before. And then you can talk to them about that experience and what they've noticed about that. So discouragement versus encouragement. They may feel discouraged, but we want to encourage them along the way. The more that you encourage these clientele or patients, the people that you're working with, the more they feel that you have their back and that you're supporting them. Remember to advocate for people. A lot of times there might be changes within a program or changes within a people or community that may make things easier. One thing that I like to do is to educate the communities, because a lot of times there are so many different factors that come into play that they might not understand either. And that is exactly where you can bring up stigma, stereotyping, and things like that, because substance abuse and mental health issues, people used to look at that, oh, this is what it is, and people were always afraid of people who might have been diagnosed with schizophrenia. But now, because of the DSM-5, they're realizing that it's no longer just one thing, it's a spectrum. And other disorders are becoming more like that, because then they realize they can have it a little bit or they can have it a lot more. So it's not always the same. Consultations with family, consultations with other professionals to be able to help your clients. Remember, it's really good to be able to have a list of all these other services that you can provide them with so that they can seek help other places. Of course, case management is very important. Remembering sure you make notes, making sure that you're working with certain peoples that might be able to help as well. And remember cultural holistic practices. So we're not just dealing with just them physically, we're dealing with them also with their emotions. And a lot of times I feel that emotions are often left out a little too much, because people need to be able to develop healthy coping mechanisms, healthy ways in order to monitor how they can help to even change the way they feel about things or their emotions so that they can deal with it. Because a lot of times people don't always treat them like that. You know, and I've been to different conferences, asked a whole bunch of people, it's like, how many of you were ever taught how to deal with difficult emotions like anger and pain and hurt and grief and all these other things like that? And most of the time, there might be only one or two that might raise their hand, but a lot of times there's none of them. Whether their parents or grandparents never taught them. So it's very important that they do learn, and to learn also to kind of overcome faulty belief systems, even about themselves. So, and also definitely with working with their mind and helping them, having maybe reading, exercise, you know, those things are helping to utilize other parts of the brain. And also to, with exercises, to release different endorphins and stuff to help them feel good. Plus at the same time, it helps get the blood moving and everything like that too. And with substances, it's very important too, because what happens is you're dealing with the brain that has been altered by chemistry. Because and it's very important, like with Lee was mentioning early with methamphetamine. Methamphetamine and marijuana do a very large number on the brain chemistry, because as these dopamine, serotonin shoot up high, your brain really wants everything to be normal. So it begins to readjust what that normal line is. And the way it does that is by shutting down receptor sites and things like that. So by the time we get them normally, a lot of these receptor sites might have been closed. And certain chemicals might be needed there. So like a lot of times it's good to be able to you know, support somebody in getting on medication that will help them feel good. Yeah. While that is going on, then their chemistry can kind of go back to normal. They say for marijuana high use, it might take 6 months for that to even back out, 6 months to a year. And I think meth is a year to 2 years. But whether it ever gets back to normal is kind of questionable. Okay, next slide.
Yeah, I just wanted to comment on that,
Okay.
Sean, that you're absolutely right. What is normal? I mean, our whole world has changed, and it's specifically for the AIVRTTAC communities. You know, these ways of handling things are, I don't think, ever going to go back to the way they were before. And I think that our resources are going to be even stretched further. But Teresa made a good point. She said, as VR techs and counselors, your job is to help the participant be the best that they can be, not what you want them to be. We can want all we want, but the participants' wishes and wants are what we're there to try to put in place. So thank you so much. I'm going to the next slide.
Okay, so working with American Indian Alaska natives diagnosed with serious mental illness. Okay, so the status quo is not enough. And while we work with different peoples, we need to remember them as individuals and work with each one of them individually and to provide them what they need individually. One program on one way will not always help everyone. So to develop the program to be able to make changes along the way to be able to help them, very important. So remembering that natives live in two worlds, the mainstream culture and the native culture, whatever that might be, Native, American Indian, Alaska Native. And that's, you can really see that definitely in bicultural peoples, but also we deal with our own peoples, we deal with our own family, but we also deal with outside individuals who are outside our culture. And a lot of times it can be a little bit difficult. But remembering that as we try to keep 1 foot within our culture and 1 foot within the outside world, we're kind of going back and forth. And sometimes that line can be a little thin. So making sure that we allow ourselves to be able to listen to each individual and to be able to work with them where they're at. So that's very important for when you look at self-identity. Providers must understand the influence of historical trauma. I think we've talked a little bit about that, but remembering that it affects the genes in a sense. It's passed on genetically. So, and one thing with Maria Braveheart is that she didn't want people to just look at historical trauma and to, in a sense, re-traumatize people over and over again, because that's what a lot of us see is that we go to other places, they're looking at historical trauma, but they're showing all these graphic scenes over and over again. And I normally have to walk away. I can't watch it all. Historical trauma, it needs to be looked at more in a sense like a diagnosis. The healing from historical trauma is the key in what Maria Braveheart was looking at. And a lot of times that is the way she does her trainings through historical trauma. Integrate traditional ideas and practices in what is often considered the mainstream. We looked at that with best practices, looking at experience-based practices, which are the traditional ideas in a sense, and also evidence-based practices. So, and again, it's like walking those two worlds and combining in a sense where things might need to be combined a little bit, or be able to utilize both or one, depending upon what's going on. Treatment must be sensitive to the natives' norms, their beliefs and culture. So it's very important that we take into account what their beliefs are, what their culture is. Even if it's not our own, we have to be able to look at that with an open mind. That is part of how cultural humility works. Cultural humility is looking at ourselves. It's more, I guess you might say, a verb instead of a noun. It's that work that we do in order to still help that client or patients. So mental health illnesses are taboo with natives. I think that is kind of changing a little bit. Long before, it's like a lot of the natives looked at mental illnesses as something that maybe the person did wrong. But we also have people within our communities who look at mental illnesses now and say, oh no, that person has a mental illness, you better stay away from them. Because they don't understand all the time, and they often forget that our culture too, we have to be able to rely on our culture and how this plays out, because we have natives who've been diagnosed with mental health issues who don't have one. And a lot of times I've met probably about 15 medicine men now who are all either diagnosed or almost diagnosed with mental health issues before they even found out that they were gifted peoples. It's very interesting when you look at it like that, because you have these people who are well known around certain areas as medicine peoples, but outside the culture, they were considered mentally ill. So in a sense, it's part of educating our peoples again. So, okay, substance use and domestic violence are both viewed as stereotypical features of Native life. Now, when we look at this, the substance use, we normally have more people on reservations and such that don't use substances than those that do. And also with domestic violence, more domestic violence is done to natives by non-natives than it is natives. So when we look at things like as being stereotypical, in a sense, we need to look at more of the facts and things that are really out there. Because for so long, people thought of natives as just drunks or something like that. And later on, they're thinking a lot of domestic violence, but also domestic violence is part of historical trauma. Because in many of the different tribes, it's like domestic violence was something very taboo. That was something that you just don't see. And a lot of times the tribes had their own way of dealing with that, so it never happened. People can be banished or never return or something like that. And a lot of the tribes have that same practice, which is very interesting. Next slide, please. Okay, so here is, you have the DSM-5 as your American mental health, and kind of a native mental health would be our culture, our traditional ways, because a lot of that is incorporated in how we deal with things the same way sometimes. Of course, we do have our healers and things like that that might be able to help us in other ways as well. But one thing I would like to say is that if people really do have a mental health issue, it is important for them, I think, to be on medications. And a lot of times there are medicine people, healers out there that say, stay away from it, don't do it. But at the same time, I have always been taught that the doctor or psychiatrists handle their things. The medicine people handle their things. So if things begin to get better, it would only make sense that the doctor or psychiatrist would lower the medications as that person gets better. So that's something to remember. Okay, next slide, please. Okay, remembering that a lot of natives are very concerned with confidentiality. Stigma is considered discrimination, and actually they are looking at other words to utilize besides stigma. And when we look at discrimination, going further, discrimination is a crime. So, okay, evidence-based and experience-based practices, we talked about that. Community inclusion of program guidelines and practices. It's very good to be able to get the community involved in how people make their guidelines or practices and within the community, because then they have a chance. And a lot of times getting that buy-in is very important because they feel then they are part of it. And remember the limitations of evidence-based practices is that not all are evidence-based practices to all peoples. Okay, next slide. Okay, so caseloads. Remember to approach these and manage them in various ways to make sure they're more balanced. Those people who might have more experience, you should not always give them all the worst clients, but to try to find a way into balance these, or those people might get very stressed and they might be overworked and they end up needing time off or something like that. So sometimes it might be good to be able to incorporate some kind of practice within the agency so that that doesn't happen. Maybe they can talk to the supervisor or something like that. They might be able to go for a walk or something like that. Remembering that also depends upon diagnoses of our clients. Factors that may come into play are social, economic, physical, emotional aspects to determining how you will manage this in these caseloads. Okay, next slide, please.
I just wanted to make a comment on the last slide on how to serve American Indians or Alaska Native mental health participants. When you were talking about evidence-based practices versus experience-based, so what we have to remember is that most evidence-based practice, let me take that back. Most vocational rehabilitation research and evidence is not in a tribal setting or in a tribal community or in any type of rural reservation type setting. So this is where our own personal experience comes into play. You know, our knowledge of our own communities, our own resources, our own practices is, as you said, Sean, experience-based. So this looks more like a traditional culture versus what most VR research and evidence is based on. Sorry, I just wanted to stick that in there.
Yeah, that makes a good point. It's always good to kind of do surveys or to look at the agency's needs and what they're doing, because you got to look at all the different cultures and all the different people you help to make sure that you're managing all these different belief systems and culture with each people and be able to make those changes for them.
And I want to add to, sorry, Sean, go ahead.
What?
I wanted to add too, when we're talking about evidence-based practices, you know, Native Americans are not typically part of those evidence-based practices. It's based on the Western world. So yes, culture is a very big part of this that we do have to consider. And when you're working with an SMI patient, you know, you're working with an SMI patient, you're working with an American Indian or Alaska Native that come with, you know, our own set of beliefs, our own set of traumas. And then you're also working with someone that may have experienced historical trauma and other types of trauma. So, you know, it's the people that you are working with are very different than a typical SMI clientele. So I just wanted to make sure that you guys understood that.
Yes, thank you, Teresa. We have a comment. Elizabeth Bull says that when I have been on teams of multiple VR counselors, we have shared the mental health / substance use disorder referrals and do case conferencing as difficulties arise for other input on how to best work with these individuals. Yes, that's great, Elizabeth, because that is a wonderful way to staff these cases with other counselors to get ideas, bounce things off of each other, and to try to have the best well-rounded approach to the case. And Adrian had a question too. She says, haven't all natives been exposed to historical trauma transmission? And I think that was a resounding yes from Teresa. We're running out of time, but oh, these are wonderful questions, and I would love for us to talk about it more in detail. Ethel is wanting to know the CFR requirements for grant reporting for behavioral health or medical reporting, such as monthly reports for medical and biweekly reports for behavioral health, also phone calls to medical and behavioral health. Lee, would you like to answer that question?
What was the question again?
Ethel Green asked what the CFR requirements for grant reporting for behavioral health or medical reporting, such as monthly reports for medical and biweekly reports for behavioral health, and also any phone calls to medical and behavioral health. So I guess she's asking, are we required in our reporting to include this information?
I don't have an answer for that question, but certainly something that we can
Okay.
check out and share our findings with the AIVRTTAC programs.
Yes, most definitely. I think what you put in your proposal is what you are responsible for reporting, right? Is that correct?
That is correct, yes.
Okay, but we'll look into that further, Ethel, and get a better answer for you. So on the slide that we're currently on, the holistic approach, we're talking about a participant's ability to work, any type of assessment. If you are in doubt that the participant can benefit from VR services, there was a question earlier from someone who said, well, what if they don't take their medications and then their symptoms overcome them or overwhelm them? And, you know, we have to always remember, even though they may be eligible for VR services based on their disability or other eligibility criteria as well, sometimes people just are not ready to go to work. And as much as we want them to, we can't make them. We can't make them take their medications or seek counseling or therapeutic interventions. So, you know, unfortunately, if they are not capable, willing, or able to go to work, that is one reason they would not benefit from services. So we have to always remember that. A psychological evaluation, sometimes you need a very thorough evaluation of the diagnosis. Someone may show up to your office and during the intake, provide some information to you. They have a mental illness, or they have a mental diagnosis. But sometimes you need to really investigate that or get a true evaluation of the diagnosis. So that's always something to remember. And then also self-management. When you talk about a holistic approach, self-management, the participant's own management of their own treatment, and that also includes traditional healing, you know, any type of traditional therapies, their medications, exercise, nutrition. When you think of holistic and that approach, these are the things that come to mind to me. So self-management using traditional healing, I think, would be considered in the holistic approach. I'm going on to the next slide. Also talking about the biopsychosocial approach. When we talk about team building, you have an entire team to work with this particular participant. You have the VR counselor, their therapist, maybe their medical doctor, their psychiatrist, any type of instructors or representatives. If they have a legal representative, that's a team approach or a team building approach. Also, when you consider biopsychosocial approaches, you are thinking about their medication and counseling agreement. You know, sometimes to make sure that the individual is receiving proper training, or proper treatment. Sorry, my screen just went crazy. You want to make sure that that individual is seeing their counselor like they're supposed to, and on their medications as they should be. So those are things we need to think about also when we talk about the biopsychosocial approach. Also biological, sometimes injuries require treatment. If someone has pain medication, pain management, you know, that's part of their biology. You know, they have to take medication for those things. Also social factors, family history of addiction, family history of any abuse, or, you know, just poverty that we see so much in our communities. These are all social factors that influence the individual. And so we need to look at that when we're looking at it from a biopsychosocial approach. And then when we're developing strategies for service provisions to participants in a mental health case, these are the things we need to know going in. We need to know the details when addressing the needs of the participant. We need to know their medications. We need to follow through, make sure that they are following through with their therapy and counseling. We also need to know, that there are just different types of cases, just like a general caseload or a physical disability caseload, the mental health or SMI caseloads, they're completely different and should be approached in a totally different way. And also knowing how mental health affects your case. So just for an example, this type of case may take much longer to work through the VR process than, say, someone who has an amputation or someone who has another physical disability or just a general caseload. There are going to be setbacks sometimes due to a variety of reasons. So, for example, the participant may go off their medications, or they may have very complex family dynamics. There's probably people in the family who are also dealing with mental illness or addiction. And people just relapse sometimes. So these are all things that, in a cookie cutter world, we'd love for things to go perfectly, but we know they don't. So that is what you always need to be remembering when working with this type of caseload. And then how to serve a mental health case or a participant with a mental health diagnosis. We want to go back to what we call the VR basics. And when I say that, I'm talking about the VR process. So good intake skills, that's key in better understanding the participant's disability and their needs. You need lots and lots of case notes because you want to keep track of exactly what's transpired during your meetings with this participant. So when, keep good observation and case notes during the intake. Also continue to case note every step of the VR process, the eligibility portion, the IPE planning, service provision. You definitely want to look at all of those things when you're going back to the VR basics. You're also looking at functional limitations of specific mental health diagnosis. So if you've got a disability handbook, and I recommend that every program have a copy of that, or it would be great if every counselor had a copy of the disability handbook, but this is a great resource guide for you to break it out and actually look at the specific diagnosis and understand, what are the impairments? What are the symptoms of the diagnosis? What's causing these roadblocks to employment? And you want to address these impediments. So for example, a lot of types of impediments that come from mental health cases are interpersonal skills, dependability, someone dealing with a mental illness or a substance abuse diagnosis, they may not be the most dependable person, and you need to be prepared for that. Decision making is difficult sometimes. Stability is very hard for this particular participant. Consistency of behavior, impulse control, even dressing proper. I think we've all had those participants that have come in and you say, oh my gosh, what are they wearing? And did they show up on the job or for their interview dressed like that? But it's just things that come with mental illness, logical thinking or adapting to change. These are all functional limitations that should be addressed when you are looking at the provision of services. So identifying them, putting services in place to remove those roadblocks to employment. And sorry, we've gone over. We have a Q&A session here, and I think we asked a lot of questions during the presentation, but now is the time. And I also want to say that we just ran out of time today. We want to talk about de-escalation, but we just don't have time.
You do have a question on the chat there from Ethel Green.
Oh, okay. Ethel is saying, so if a participant has been put on hold for physical therapy due to COVID-19 and has not been released by his main provider, but released by surgery provider, he can do self-management for their medical release to go back to work, employment. I'm a little confused about that question, Ethel. You want to explain it a little more?
Well, he had back surgery, and then he got that done right before COVID. So then COVID came, and then he couldn't get back into physical therapy. So he's been delayed for over a year. But so if we do self-management where he's doing his own physical therapy, and that goes for any, for people that are on medical for obesity, they do their own self-management, right? So that would be the same thing for him. He could do self-management on his own PT so that he can return to work. Or does he still need to get that doctor's release? Because the doctor, the main provider at the clinic will not sign. He referred it to the surgeon, and the surgeon referred it back to him. So it's just been sitting there, and he's still waiting to get some confirmation of he can go back to work. So that's holding up services.
So you said the surgeon released the individual to go back to work, but the primary care physician did not? Is that what you're saying?
Yeah, the surgeon released him to the provider instead of releasing, he wanted the provider to release him. But the provider referred him back to the surgeon to get released. So it's been going back and forth, sort of.
Have you seen any notes, any medical notes, or is that just what the participant is telling you?
I'm sorry, what did you say?
I said, have you actually seen any medical notes from the surgeon and from the provider? Or is that what the participant is telling you?
No, we got the referral from the provider, the clinic provider, stating that he wanted the surgeon to release it. So then the surgeon referred it back to the clinical provider.
Well, I mean, it sounds like the primary care physician referred him back to the surgeon to make sure that everything was good to go. And then the surgeon said, yeah, everything's good to go. So it sounds like to me that you should go ahead and get a release to return to work and have that individual start getting back involved with their case. That's what it sounds like, but you know your participant better than we do. Does anyone else have any questions? I think we've lost a lot of people. The time went over. John is reminding us that we do have a survey for today's presentation. So please, 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 we're asking everyone to complete the survey, fill it out. It really helps us, gives us feedback on what we did and didn't do correctly, or what you would like to see in further presentations. So it's really good information for us to build upon if you fill out the survey. I want to thank Teresa and Sean. Here's their contact information. And it'll also be up when we send out our weekly announcements on Friday. The link to this recording will be available with their contact information. And I also want to remind everyone that the next webinar is on May 26th on counselor burnout. And we would like to invite you to participate in that. I think it'll be a wonderful presentation. And then we'll also have a talking circle on June 9th to talk about dual diagnosis and counselor burnout. And Lee, I'm sorry, what were you saying?
I was going to say, or ask Teresa and Sean if they have any material on what they consider cultural competency. I know they didn't exactly use those terms, but I was just wondering if they had any written material on cultural competency that could be shared with the counselors primarily.
We actually have a 3-day training that is designed for that.
I see. Okay. Um,
At least our center is very big on making sure that everything we do is culturally competent. That is one thing that we strive to do.
okay. Maybe during next webinar, you might want to share that information with us because I've been trying to locate information primarily from a Native perspective as to what cultural competency really means. I say that because while I'm Native, I don't want to say anything that would come across that may seem that what I'm saying is the gospel truth without being considered that we all come from different nations. You know what I mean?
Yes. And it's really culture inclusiveness, cultural competency, you know, is being aware of the culture, and we have trainings on that, but we really need to start working on incorporating Native nations, true culture in our beliefs, just like what Sean was saying, you know, how we need to connect with our culture and some of the other things that he was referring to. And yes, every Native nation is different and we have our own beliefs, but there are a lot of commonalities between Native peoples.
And I think it's also I think it's also an appropriate topic to consider given, you know, what is happening out there in the world. You know, the hatred against and the violence against certain minorities.
Absolutely.
And why it's important to talk about, address, and set up some type of protocols for cultural competency within our own respective organizations.
I agree, Lee. You know, when I lived and worked on the Hopi reservation, I received this little, all new employees received this kit, and it was a little booklet, and it was like a pocket folded thing. It was really small and you could fold it up, but it did a comparison across all tribes and culturally what was acceptable, not acceptable, um, you know, norms or beliefs and things like that. And it was really, I mean, I thought it was a great publication. I have a copy of it and I'm going to try to find it, but it did come from the Hopi tribe.
And what also concerns me is that I really appreciate staff who are non-native, but who are also working on our respective tribal goals and objectives in serving certain target population. And I believe we need to make sure that we embrace those individuals into our cultural setting, and also request that they share with us their cultural background so that there's some common understanding as to where we're coming from, and not make assumption on certain behavior within our work environments.
Absolutely. Thank you so much, Lee. So if no one else has any comments, I think we're going to wrap up. We did go over. I apologize for that. Teresa, Sean, thank you for your time. And again, for a wonderful presentation.
Yes,
Have a
thank
great
you.
day, everyone.
Yes.
Yep, thank you. Everybody
Thank
have a
you.
wonderful day.
Hi, Sean, are you still on?
I'm still on.
Hi, this is Paula. I put it in the chat. You had mentioned there's a 2-day training that you spoke about.
I think that a lot of times what happens is people from a certain area and stuff like that, if they would send us an invite or something like that to be able to talk about that, we can go out there and do that unless we want to do that online as well.
Right now, we're still doing things virtually, but I just wanted to make a request for our counselors. We have a pretty large staff. We have 9 counselors and 9 VR techs, supervisor. So I don't know if you're open to that.
Yeah, we're actually always open to that. We really would like to do that. Let's see.
Paula, are you,
Here's my email. If you want to send me an email, then you can request that, and I can send that to the proper person to make sure that we can start getting that organized.
Paula, that's for the culture competency training, correct?
Yeah, we call it the Native American curriculum.
Yeah. Mhm.
Yeah,
I'll tell you
and then
something else
also,
I'm interested in.
is there
Sorry, Paula.
I'll send you an email, and then also anything on, maybe repeating this particular training a little bit broader.
Mhm.
Or allowing more time.
Mhm. Yeah. Yeah, most definitely, Paula, we're going to, so many topics keep coming up during our training, and we want to add to it, build upon what we've already done and even delve deeper into some of these topics. So send any suggestions you have to AIVRTTAC, and we'll be glad to move forward.
And Sean and I are both, our email addresses is on the last slide too. Please, also, if you ever want to reach out to either one of us. Is that correct, Jamie? Yeah.
Absolutely.
Yeah.
Yes. Yeah, it was. And we send out the, I think John put a link to the PDF of he said he was going to try something new today. And he actually put a link to a PDF of this PowerPoint in the chat. Do you see it there, Paula? And then folks can,
yeah, the slide deck.
and then you can get Sean and Teresa's contact information from there as well.
Sean, you want to tell them what the culture cards are that was developed? I know that we have.
Depending upon which culture cards you're talking about, the first one that came out was the cultural card by SAMHSA. And if you get a hold of SAMHSA and request those, I think you can do that online. They'll send you a whole bunch of them that you can use throughout your center and give them away or anything like that. We also have some of our own in prevention that was developed by somebody in our staff, some of our help, but a lot of people really liked it.
And what they are is they're just
Yeah.
little handheld, kind of like a mini poster, I guess, that you just kind of fold and open with good information on there. All right, can we go, Jamie? Are we good to go?
Yeah, we're good to go.
All right, thank you,
We
everybody.
can talk with you guys all day. Thank you.
Okay, bye.
Have a great one. And I'll be touching base with you, Teresa.
All right, sounds good. Thank you, everybody.
Thanks so much.
Thank you all.
Have a good one.